This is another edition of IU Case of the Day, and we're going to be talking about an abdomen case. My name is Antonio Aguilera, and I am a PGY5 radiology resident, and my staff helping me on this case is Ted Seltman, who is an assistant professor in the body department. All educational content herein has been fully de-identified to protect patient privacy. Our case begins with a CTA for a pre-Tavor workup. I'll give you a couple of seconds to take a look at the images and gather your thoughts. So our first image is from a CT from 2008. So this was about 10 years ago. And here we can see that there's a density in the gallbladder fossa. Now we're fast forwarding to the patient's most recent CT exam. And here we can see that in that same area we no longer see the density. And all we see is a soft tissue stub. But just to the left of this, at the level of the mid-CBD, we can see that the density is there now. So what's your diagnosis? So this was intraductal migration of cholecystectomy clips. So in general, there's about 600,000 cholecystectomies that are performed annually in the US. 90% of those are performed laparoscopically. Intraductal migration of cholecystectomy clips is a very rare complication, and it's seen almost exclusively in the realm of laparoscopic surgery. There's only been a number of case reports that have been described for this entity, and the precise mechanism is not well understood. However, an important thing to remember is that these clips can serve as a nidus for stone formation, and it leads to the coined term clip cholelithiasis. So like stones, these clips can cause complications related to obstruction, such as cholangitis and pancreatitis, and this warrants a call to the ordering physician. On this less remote KUB, we can actually appreciate the cholecystectomy clips within the mid-CBD. So just to recap, intraductal migration of cholecystectomy clips. It's not difficult to identify, as we can see in this case, but it may be easily overlooked. Clips are far more likely to migrate out of the gallbladder fossa and into the peritoneum than intraductally. However, whatever the location is, this warrants a call to the ordering physician, as this can serve as a nidus for infection, inflammation, or obstruction. So I was able to find a case report on acute cholangitis following intraductal migration of surgical clips. This was almost 10 years after the laparoscopic cholecystectomy for this particular patient. I want to thank IU and Ted Seltman for helping me on this case.